Thank you very much, Omar. So, thank you very much for inviting me to talk at this conference. It's an honor. I was initially quite surprised when I asked. I don't know much about drug delivery to the lung, but the organisers were very persuasive, and said, "Why don't you talk about something you do know a bit about?" So as Omar so rightly pointed out, I've spent most of my career working on preclinical in vivo models of respiratory diseases, mainly at Imperial College in London, but now more recently at AstraZeneca. So often the thing posed to me is, are preclinical animal models useful, or are they just really a waste of resource? So that's what I'd like to talk to you about. So, well, are in vivo models predictive of clinical outcome? Is often that's a thing we talk about a lot. I predominantly work with mice, rats, and guinea pigs. Guinea pigs because they have a cough reflex, unlike a rat and a mouse. And we're trying to model the human disease. And already it's a tough ask, because the physiology of a human lung to an animal's lung is different. The pharmacology is different. The immunology is different. Pretty much most of the ologies are different from a small rodent to a human. So already where it's difficult to do. And then you've got the fact that the diseases our research into asthma, COPD, and IPF are heterogeneous in their drivers. We don't really know what causes them, and only what the text on the top right is trying to show you, not so much how many people have them, but what small percentage it is of total people that get these diseases. So again, it's a small population of the people that get these diseases. And the sort of buzzword now is precision medicine, where we select out a subgroup of, say, asthmatics to treat. So you can see how difficult it is, how far it is away from the simple inbred mouse to this complicated disease in humans and precision medicine. So my original idea for this talk is to tell you all about how difficult my job is and how hard my life is. But then I just realized I'm being bitter and twisted, and I thought, actually, it would do. I'm sure you know a mouse is not a human. So what I thought I'd do instead was give you like a case study of where we have built up some evidence for a particular target, tested it, and then how it's not quite worked out, but how we're trying to change that. So one of the main things we research at Imperial College, along with Omar, is chronic cough, and how bad it is for if you suffer from it. Just, I'm sure you're all aware if someone has cough, but just to give you an idea, that top left graph on the slide here is showing the reasons why people visit their GP, and you can see down the bottom, the one that I highlighted, cough is the predominantly the reason why someone will go and visit a GP. So it is an overwhelming burden, and whilst it's not life threatening, it has huge physiological and psychological and social implications with someone who suffers from chronic cough. It's not only you, it's the persons around you, going out, socializing. It's a massive burden, and there is no real therapies. All the treatments you can buy at a chemist generally just don't work. I currently have got a bit of a chest infection. I've been coughing for about a week now, and that's just a week, and it's caused me loads of problems. I can't sleep, and my family is suffering. Last night, I think my wife was going to kill me with a pillow. I was coughing so much in bed. So it is a bad thing, and there is no treatment. Just to show you just to give you some sort of representation of how bad it is, there's some lovely work done by Professor Jackie Smith at Manchester University and her colleagues, where they use a cough recording device that records chest movement and records the sound on people for 24 hours a day. And what they did is they compared the number of coughs in healthy subjects, controls in a white bar, with a whole range of respiratory diseases: asthma, COPD, IPF, lung cancer, and people with chronic idiopathic cough. And you can see here, this is a linear scale, that they're all coughing a lot more than a healthy subject. So it's a big problem with an unmet therapies, unmet need. So the case study I'm going to tell you about is where we built some evidence around a particular ion channel, TRPVI, and we thought that was driving some of this cough phenotype. Just to give you some background for it, this is a very simple schematic of the cough reflex, the airway reflex that's cough. And down the bottom of the diagram, you've got the lungs. This is trying to show you where the nerve endings terminate. It's generally in the larger airways, the trachea and the first bifurcation. And on those nerve endings, an array of sensors, ion channels or GPCRs connected to ion channels. And they're there to detect something that shouldn't be there. And as they detect it, they fire a message up the vagus nerve via the C fibers and the A delta fibers as an action potential past the ganglia for the sensory nerves to the lower brainstem, and then that instigate the motor nerve to trigger the cough response. So in a healthy subject, you're sitting there, you drink your orange juice, it goes down the wrong hole, these things detect it and cough it up when it protects your lungs. All good. But in a disease, in a patient with respiratory disease or idiopathic cough, they're having all the time. There's no reason for it. It's just coughing, 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 and it's horrible. So we set about building up some data to suggest this ion channel, TRPV1, could be involved in driving this response. So one of the very simplistic systems we use is this vagus nerve prep we have. So we can harvest vagus nerves from mice, rats, guinea pigs, but also from human lungs through donations we get. And then we put the vagus nerve into this prep, use Vaseline to isolate both sides, and then look and measure depolarization across the two ends upon stimulation with an agonist, a TRPV1 agonist in this case, and then an inhibitor to show it's blocked. And using this prep, we and a lot of others have shown that TRPV1, the ion channel TRPV1 on centromeres, can be activated by a whole range of stimuluses, including low pH, temperature, a lot of things that are around in the disease lung, but also things like PG2 and bradykinin, which activates their GPCR, which then causes the opening of the ion channel, and then depolarization of this nerve, which is a precursor to action potential. And just to show you what it looks like, the bottom graph on the right, or the bottom figure on the right, is a human vagus nerve, and we've stimulated it with an agonist. In this case, it was a TRPV1 agonist, capsaicin. It causes depolarization. You then wash it out, and you get it again, so you can get two reproducible responses. Then incubate that vagus with an antagonist, say a TRPV1 antagonist, and then re-stimulate with the agonist, and you can show it's a very diminished response. You can wash it all out and then get the response back. So it's a great way to look at particular ion channels using the native channels using human tissue. So this is the sort of prep we use. So from this, we know that if you activate TRPV1, you can activate airway sensory nerves, which should lead to a cough response. To take this a little bit further, we then started to use our animal models. And as I said before, we use guinea pigs typically because guinea pigs have a cough reflex, and their nervous system, or the airway nervous system, is very similar to humans, unlike rats and mice. So what we have is our model of COPD, and I'm sure you all know, but cigarette smoking is number one driver of COPD. So we expose the guinea pigs to cigarette smoke an hour in the morning and an hour in the afternoon for 8 days, and that gives us our COPD-like phenotype. We then harvest the vagus tissue from these guinea pigs and compare the responsiveness to a TRPV1 agonist compared to the air-exposed controls. And you can see on the right at the top, you get this much bigger response to TRPV1 agonist compared to the air control. So this outside of the body, these sensory nerves have changed their phenotype. They're more sensitive to TRPV1. So which is giving more evidence to suggest that in COPD, maybe TRPV1 is driving it. And over the years, through the collection of vagus nerve from non-smokers' lungs and smokers' lungs donated to us, we can again show that in the human vagus, they are also more responsive to TRPV1 compared to their non-smoker controls. So we have that translation between our guinea pig model and our human vagus, which is really encouraging. So we've got that A, TRPV1 will activate sensory nerves, and B, in a COPD environment, they seem to be more sensitive to TRPV1 stimuluses. So does that lead to cough? So on the left panel, what we've got here is the same guinea pig model, but instead of taking the vagus out, we're actually now challenged the whole guinea pig to inhale capsaicin. And you can see, compared to the air-exposed animals, that the animals exposed to cigarette smoke previously are now coughing a lot more to TRPV1. So they're more sensitive to it. They're actually coughing more to it. So again, more evidence suggests that TRPV1 is the thing that's driving this extra cough response. And what Jackie did and her colleagues did in Manchester was she compared healthy subjects to subjects with COPD patients. And this is slightly different to how we've done it. What she used to do is keep increasing the capsaicin challenge concentration until they got to 5 coughs. So now it's the opposite way around. So now the COPD patients are coughing 5 coughs, a lot lower challenge of capsaicin. So now they're more sensitive. So again, very similar to our guinea pig model. In the human phenotype is the same. So again, there's more evidence suggests that TRPV1 is possibly involved in this cough response. So the next obvious thing to do is to try and block it. So we would collaboration with this company called Zentium with this compound 0501, which is a really good oral TRPV1 inhibitor, and we showed on the left-hand side in the vagus, guinea pig vagus, that increasing concentrations of this compound causes a lovely concentration inhibition of the response to capsaicin. So it's working really well. And I haven't got it on there, but it's actually nanomolar concentration. So it's a very potent compound. And again, using the human vagus tissue, we can show that the same thing in human vagus. So we're now using the native channel on the sensory nerves, showing that the compound we want to test is working really well and very potent. But now we can take that compound into our disease model. So initially we did it in naive guinea pigs just to make sure we got the dose right. So this is guinea pigs that are pre-dosed with the vehicle or the placebo or increasing doses of the Zentium compound and then challenged to capsaicin, and then we counted the coughs. You can see here we get a nice lot of coughs in the vehicle group, but as you increase the dose of Zentium, you've abolished it completely. So it's working really well in a naive animal. And then when you bring it down to the disease model, our COPD model, you can see the grey bar compared to the white bar, we're getting these increased responses to capsaicin in the smoked guinea pigs, or guinea pigs supposed to smoked. But the compound's still blocking it just as well. So at 3 mg per kg, the oral dose worked really well, whether you're air exposed or cigarette smoke. So up to this point, we're very, very confident this compound's a great compound, and we've got target engagement, and it's looking good in the animal model. So then it comes to Jack and the team doing the actual clinical study. So what they did was, if we focus on the graph on the left, first of all, they did a basal cough response. And this time they're challenging to a certain level of capsaicin and showing their coughing, counting the coughs. And then they dosed twice a day with this compound for 14 days, and then re-challenged with capsaicin, the TRPVI agonist. And you can see the placebo has no effect on the capsaicin response. It's just the same. Whereas the patient's dosed with the Zentium compound has a marked reduction in response to TRPVI agonist. So we've got target engagement in the patient's group, which is all good. But when they come to actually count the number of coughs, the objective cough scores in those patients, you can see here that the placebo and the drug-treated groups, there's no real difference. It wafts around the same time, all of it. When you can see the coughs when they've first in the morning time, it's coughing all the way until until they go to bed, basically, and when they're asleep they don't cough, and then when they wake up they cough more. But the big message was there was no inhibition, no suppression, which obviously we were very disappointed with. And again, a few eyebrows were raised about this: is the animal models predictive or not? Which is always fun for me. But I'd argue actually the models were. When we invoked the cough response for capsaicin in the guinea pigs, we blocked it. Same thing in the clinic. But when it came to the spontaneous cough, this is a picture of a guy recording equipment. There's a cough, the monitor of his chest movement on his chest, and then the device around his waist to actually count the coughs. That's when we didn't see the effect of the drug, and that's what we're missing, that spontaneous cough part in our preclinical model systems. So the next part of this is trying to show you how we're slowly trying to put that right. So at the time of this finding, we had a PhD student join us, John O'Miles, to do a PhD. He had previous experience on a bleomycin-induced IPF model. So we set him to say that you've got your experience on this model. How can we measure cough in guinea pigs? Spontaneous cough, not cough where we've induced it. And so he set up with our colleagues. He set up this system here that's depicted in the cartoon, where he used sort of a camera, a bird box type camera with infrared sights on it, so you can see them at night time and during the day, and then linked it to a microphone as well, so you can see which guinea pig coughed in the cage. That cartoon on the right is trying to depict what it sort of looked like. Each cage of guinea pigs have a recording, and we can record using this device 7 days a week, 24 hours a day. So what he did in a small pilot study was he induced the fibrosis of bleomycin, which is dosing bleomycin to lung on day 1 and day 4, recorded all the footage of the guinea pigs over the 21 days, and then set about assessing it. So this is not worked. Hang on. It's not going on. Hang on. The next slide is really good. Oh, Mark, can you see the next slide? I can't get it go forward.
Sorting it out while we're live on it.
Okay, all right, sorry.
So the technicians working their magic.
So we've got your cough-in disease on the idiopathic pulmonary fibrosis, and we're just trying to get the next slide sorted out for you, Mark.
No worries, no worries. I can try and describe it. So this is a pilot study he did, and only a few guinea pigs. And then after the 21 days, he took the lungs out and assessed that he's got fibrosis. So in the ones given the vehicle for bleomycin, there was no real fibrosis. As you increase the dose of bleomycin, you got a lovely increase in fibrosis. So the model worked. We've got fibrosis. The question was then, did they actually cough? We sat down before we started to count the coughs and worked out that if Jono was to sit there and count the coughs from all the cages from all the hours, it would have been 2,500 and something hours, which, you know, is a long time. Even for a PhD student, I'm not that mean. Oh, there we go. We're back on it. Back one. That's it. Right. So this is the data on the right. On the left, sorry, is with the fibrosis. You see a gorgeous increase in fibrosis assessed by Ashcroft score. So what he did is he decided we can't possibly count 2,500 hours of coughing because he'll have to sit there and listen to 2,500 hours. What he spoke with us and the vet and decided that if we did 2 hours in the morning, 2 hours in the evening, that might capture the sort of active period for a guinea pig. But even so, that was quite a lot of time for him to sit there. So he's basically sit there and listen to and watch guinea pig cages for hours on end. But the data was worth it. You can see the animals that have got saline or the vehicle for bleomycin didn't cough at all. But as you increase the fibrosis, you increase the bleomycin dose, you coughed more. So this is the first time anyone's ever shown spontaneous cough in a guinea pig model system. So whilst it took a lot of time and effort, it was worth it. I'm really, really pleased. So what he did from that is then decided to select a dose of bleomycin and increase the N numbers and do a bit more investigation. So I'm hoping to go next slide. There we go, next slide, good. So on the big panel in the middle this is where he increased the N numbers to 6 and looked over time. And you can see here on the bottom, the saline treated guinea pigs just basically not coughing at all. But whereas the ones given bleomycin, that second dose has triggered this coughing, and it's lasted out for 21 days. It's not a huge amount of coughs. It tends to be two an hour, but they are coughing significantly. And then he went back and picked 2 time points, arbitrarily picked 8 days and 16 days, I think it says 14 days, and then looked for a cough for that whole 24-hour period. Bear in mind, it always takes a long time to count these coughs, so you couldn't ask him to do too much. But you can see in that top right panel, through a 24-hour period at 8 days and 14 days, you've got this significant increase in cough response. It's quite varied, but that's the nature of cough. They tend to be quite varied. So that, again, was very exciting. And then he broke down that, just to show you the data of 14 days over time. You can see that at midnight to basically midday, the guinea pigs are coughing quite a lot. And because they're nocturnal, that's when they get to go to sleep and they're not coughing. And then when they start waking up, they're coughing more. So it's exactly as Jackie would get, but obviously inverse because they're nocturnal compared to humans. So this is where he's got so far. Him and the team are busy trying to work out what's driving this coughing by assessing mediators in the lung of these animals and seeing what's triggering the cough. It's also obviously starting to do intervention studies to try and reverse it. One of the biggest things they're doing is working with Jackie and trying to use their algorithm that she uses, which it enables them to filter out the non-cough times. So when in a 24-hour period, generally the algorithm will take out pretty much 23 hours of time that people aren't coughing, and then you've only got a cough for 1 hour, which means that drops the workload down for Jono a lot if we can use the same algorithm on a guinea pig. The other thing we're doing is working with AstraZeneca, see if we can actually automate the cough counting, which means Jono can have a lot more free time and spend less time looking at videos of guinea pig cages. He's also, him and the team are expanding the phenotype, so looking at models of COPD that I described earlier and asthma. And our eventual goal is hope to go back and retest that Zentium compound in COPD spontaneous cough and show if we could have predicted the negative result in Jackie's patients. And that's but still lots to do. But I think it's a very exciting time, and I hope I've sort of shown you how we've trying to improve our preclinical models as we're going along. That just leads me to thank you for listening to my drivel, and if you've got any questions.
Mark, thanks very much. That was a superb presentation. We've often talked over the last 4 years here in Drug Delivery to the Lungs about actually talking about cough and bringing animal models in together, and you brought that in really nicely for us. So a good few questions, Mark. So let me just kick off. It's staggering that you showed that data on unmet need and how we underestimate cough, not just on its own, but as part, as you were describing, you've got a chest infection, people with COPD, and the model that you've developed, people with asthma, interstitial lung disease, and the breadth of research that you've done. Should we treat cough as a symptom?
I strongly believe we should. I've met and spoken to people that have this idiopathic cough and cough with disease, and it's such a burden on their lives. You can imagine if you've got a lung, asthmatic lung or a COPD lung that already is compromised, and then you start coughing on top of that, it must be terrible. I fully understand you got to be careful when you treat cough, because often it can be a sign of something. So you don't want to just blankly treat cough, but I think talking to Jackie and her colleagues about their first test of something that might actually work in idiopathic cough, that gefapixate compound. it worked really well against cough, but a high dose, it stopped the taste. But people were willing to put up with not being able to taste food because it improved their cough. That's how much they want their lives better. You know, they're willing to not taste anything the rest of their lives, but still affect to bring their cough down. So I do believe, Omar, that we need it. And I think if we've got a good one or a good ones, people will then understand it and appreciate how better it is for people.
You know, it's debilitating, as you say, on patients who suffer from cough, and again, that's underestimated. I know, Michelle, you've got a couple of questions, but I'm just going to ask. So, how do we reach that balance of finding a drug that doesn't abolish the cough reflex, because it's supposed to be a protective, it's a phylogenetic reflex, it's the brain saying, look, you've got a peanut in your air tubes, cough it out. So tell us about the pharmacology and trying to sort that out. We don't abolish the cough reflex, do we?
No, that's right. So we've got two approaches. First of all, if you're looking for a global antitussive, the idea is to treat it like you would do blood pressure. You give it enough to reduce it down to a safe level. That's one option, sort of a global antitussive, suppress sensory nerves, and then you're not coughing too much, but you can get on with your life. But what we really like to do is work out what's driving the cough and presume that's different to normal protective cough and just target that. So what we've got with AstraZeneca is different programs looking at particular drivers, obviously not TRPVI right now, but are different drivers, and also looking at a global suppressor of sensory nerves. And the idea is about getting the dose right of the global one, or finding out which disease, i.e. it could be different for asthma and COPD and IPF, and in which case you cater the drug accordingly. But taking down the driver of the excessive coughing rather than taking down all coughing, because you're very right, you don't want to take away your protective effect.
Yeah, no, and the analogy with high blood pressure and is really clear. No, thanks, Mark. Michelle.
Yes, thanks, Omar. So, Mark, yes, just a couple of questions from me. Going back to the title of your presentation, are preclinical models a useful asset or a waste of resources? And over the years, we've had the constant debate around, should we use preclinical models? Are they old hat? Should we just move on? And there seems to be an increasing prevalence now on in silico technology, on ex vivo. Are there any systematic mismatches between preclinical models and the human clinical observations? And from your perspective, where's it likely to go? Do you think we'll ever replace them, or do you think we'll just make do based upon the trade-off of what they deliver versus the challenges of actually developing meaningful predictive models in silico?
Yeah, I completely agree. I think it's very hard to model a disease that we don't know what drives it. Even with COPD, which we presume is driven by cigarette smoke, I can't model the human disease very well because it's a long-term model. It's often disease of the age when you get older. So I'm trying not to cough. Ironic. But yeah, I think we should. I like the acute PD models to help drug dose demand predictions and exposure levels, and I wherever possible try to use, as you say, human cell-based, tissue-based assays wherever possible to validate what you find. I think they still have a use in life. I think they're a benefit, but it's about a question of doing the study right and interpreting the data correctly. That's what I'd say.
Okay, so Mark has clearly defended that it's not a waste of resources, Michelle. Mark, you talked about gefapixant. There's lots of development now, and you talked about side effects. So, and these, the treatments have been given parenterally or orally. What about the inhaled route? Could we improve the therapeutic ratio by trying to maybe get the formulation right and delivering these drugs to actually where they're needed, the lungs, and then try and avoid the systemic stuff?
Yeah, I think again, that's something we're working at AstraZeneca a lot. I'm sure other companies are as well, about targeting into the lung and then not systemically, as you so rightly say. I think that's the same for a lot of drug delivery for other targets as well, but it's more complicated, or as an extra complication, because you've got to hit those sensory nerves. Sorry. So you've got to hit the sort of the upper airways or the larger airways, and maybe not so much the parenchyma. So it's about getting it targeted in that area is going to be quite tricky.
Yeah.
But I think it's not beyond us. I think we can do it, but it's another level of complication because, well, we're not used to targeting just a certain area of the lung.
And And might it be in the same way we've got asthma and COPD, we don't use one compound, we use a variety, dual or triple. Is that something that the world of pharmacology has thought about and trying to combine? Because we don't have much in cough, do we? I mean, we use, sometimes we try inhale corticosteroids, sometimes we maybe wrongly, low dose opiates. And so the current story on the P2X3 is really exciting for the patients that we see, and certainly in the science that you're exploring. Might there be a dual or triple therapy for cough?
I think so. I think what triggers cough is probably multimodal as well. I spoke very briefly about precision medicine, and it may be we have to sort out multiple therapies for cough, or even a subpopulation of people with, say, asthma or COPD that would respond to the therapy. Other channels we're working on are triggered through by oxidative stress, for instance.
Yeah.
And so if we can work out what that's driving in those patients, and what disease or subpopulations have oxidative stress in the lung, that's what we'll target. But it certainly won't be one drug fixes all unless you go for one of these global antitussives, which has its own issues, as you so rightly said, about suppressing the cough reflex.
Yeah. Mark, that's
Thank
brilliant.
you.
We could go on and ask lots of questions, but we've sort of come to the end of our time. Thank you so much for connecting. I know you've got some really important meetings that you had to give up to come. But hope your cough gets better, Mark.
Thanks
All
very
right.
much.
And take care. Thank you very much,
Thank
Mark.
you.
Thank you. Bye-bye.